Welcome to Gracefully Greying. I'm your host, Attorney Henry Gornbein. Every week on Gracefully Greying, we explore issues that we face as we are aging or have aging parents. Today on Gracefully Greying, I'm pleased to welcome as my guest Dr. Joel Miller, who is not only an ophthalmologist, but has a subspecialty with regard to the retina. And we're going to learn a lot about that today. Joel, welcome to Gracefully Greying.
Thank you.
First of all, why don't you tell our viewers, first of all, why you chose this area of medicine and a little bit about your background and training.
When I was in high school, my first job was a photographer's assistant, and I had aspirations of becoming a professional photographer. After a couple of years working with him, the gentleman who I worked for was being very kind when he said I should probably go into medicine because A, I'd make a better living, and B, I think he was trying to say that my photography just wasn't all that great. And being left-brained, good at math and science, I think it was a very good fit.
And tell us why you decided, well, photography and the eye clearly is a fit, but you went not only beyond ophthalmology, but you have a very advanced subspecialty. And what is the training for that?
Well, I'll back up a little. My dad, as a physician, influenced my youth as well.
What was his specialty?
He was a general practitioner.
Okay.
But what fascinated me about ophthalmology is the analogy between the eye and the camera. And in retina specifically, you could argue the retina is the equivalent of film in the back of a camera. So when the eye focuses an image onto the film, the image and the information is then conveyed via the optic nerve to the brain. But the retina is kind of the part of the, in my opinion, the most important part of the eye, but again, I'm a little bit biased. There are several other subspecialties of ophthalmology. First of all, there's general ophthalmologists who do primarily a little bit of everything, including cataracts and perhaps LASIK surgery, which is a recontouring of the cornea so you can eliminate glasses. There are glaucoma specialists. Glaucoma is a disease where you have high pressure that causes nerve damage. Then there are oculoplastic surgeons that can fix broken orbits, droopy eyelids, that sort of thing. There are pediatric ophthalmologists that can straighten deviated eyes, which is very common at birth, crossed eyes or eyes that drift out. And then there are neuro-ophthalmologists that study the pathway between the eye and the brain specifically and evaluate patients with strokes. And then lastly, retina, which is my specialty.
And how did you pick that specialty? I mean, was it a natural thing with the photography and the lens coming to the lens of the eye, so to speak?
Well, after I went into the field of ophthalmology, you rotate through the various different subspecialties, and I just thought that the retina specialist seemed to be the smartest and the coolest of the breed, and I just wanted to be one. And the type of surgery you do is very sophisticated. At least 35 years ago, it was cutting edge. Now it's less advanced, but retina specialists were the first ones to use laser, for example. And 35 years ago, the thought of a doctor employing laser was very geeky, and it was really the technology of the field that set retina apart from the other subspecialties that attracted me.
Joe, why don't you explain to us a little bit about the parts of the eye so that our viewers can get a better understanding. And you brought this model, so that would be very, very helpful.
So this model shows the outside of the eye, which we call the sclera. If you open the eye up, the very back of the eye, inside the inner lining, is where the retina is, and it's basically the whole inside of the eye. It's not just a little patch, but the whole back of the inside of the eye. And the other parts of the eye most people are familiar with, or should be familiar with, are the cornea, which is like a watch glass, like a crystal on your watch. And then the lens of the eye, which is actually in the eye and allows you to focus rays of light, variable. And when cataracts form, it's a cloudiness of the lens, and cataract surgery consists of replacing this lens with a fixed focal length plastic implant that would go right inside the eye. Again, I don't do cataract surgery, but We often have, as retina specialists, we often deal with patients who have floaters and flashing lights, which occur commonly after cataract surgery.
Why don't you tell us a little about the eye as we age, because our demographics for this show are really 50 and over or with aging parents, and our eyes are critical. And I found, well, I recently went through cataract surgery, so I understand a little bit about that, but what are some of the things that happen to us as we age?
So cataracts are probably the number one change that occur naturally as we get older. By age 70, almost everybody has an early cataract. And the age of onset is quite variable. For example, if you're diabetic, typically you'll get cataracts at a much earlier age. And genetics play a role as well. Some individuals with good genes may not require cataract surgery until they're 80 or even older. My grandma lived to 99 and never had cataract surgery, although she certainly had a cataract. But a cataract is a cloudiness of the lens of the eye, and the earliest symptom of cataract would be difficulty with night vision, because the lens grows as we age, and the cellular tissue, as it grows, gets compacted, and the lens of the eye becomes denser, and light refracts more, and it's more difficult for the light to pass through an older lens just because it gets denser and darker. So basically what that means is if you're doing a lot of night driving, you may find it difficult to drive at night because the eye naturally requires more light at night. That's going to be the first symptom. Later with cataracts, an individual would have difficulty with vision, reading perhaps. As the lens changes, the focus of the eye will change. As the lens becomes more densely cataracterous, it becomes more difficult to focus, and that change is called presbyopia. So anyone over the age of 50 probably knows you need cheaters or reading glasses in order to help you focus the lens up close. So those are the two most common changes
What is
with
the
age.
reason, Joel, for being nearsighted or farsighted?
So a nearsighted eye is basically an eye that's larger than a normal eye. If you consider this eye to be, quote, normal, somebody who's nearsighted, the eyeball itself may be 50% larger in volume. And if the eye grows, if the eye is just larger in size, the focus, instead of being on the retina, the focus will be in front of the retina, perhaps where my finger is, and it's called nearsighted because the light is focused near or in front of the retina. And farsighted is the opposite. It's an eye that's smaller than normal, and the focal point would be in back of the retina. In order to correct for nearsighted or farsightedness, you use corrective lenses, either converging or diverging optics, depending on whether the eye is farsighted or nearsighted.
Now, does our nearsighted, farsighted, do these change as we age?
Generally, the eye grows until you're through puberty. So if someone has the propensity to be nearsighted, that will get progressively worse, typically until you're 18 years of age or so. But an emetrope, which is someone with a normal-sized eye, their eye tends to remain normal throughout life in terms of size.
Then I'm curious now, because I've had, over the years I've had prescription changes, so what would be the reason for that?
Well, again, if there is a small percent of myopes, or very high myopes, individuals who are very nearsighted, whose prescription will continue to change because the eye itself is growing. As we age, though, and cataract forms, the lens of the eye will change the refraction of the eye, and that is also a reason why glasses may be required. And then lastly, as I mentioned earlier, presbyopia, which is just the inability of the eye to focus up close. You'll need reading glasses to allow you just to read.
So is this why, as we age, typically in our 50s, that many of us need either reading glasses or we start going into bifocals or trifocals?
Correct.
And for some reason, I went with monofocals, and what would be the reason for that?
Well, I don't prescribe glasses, and I'm not a general ophthalmologist,
Okay.
but some individuals who, especially who've had cataract surgery, can set one eye for distance and one eye for near. When you wear spectacles, the two eyes have to be matched. because it's difficult to fuse an image and see stereoscopically if one image on the retina is much larger than the other. So if you wear contact lenses, one theoretically could have one eye set for near and one for far. And when cataract surgery is done, you can similarly set the eyes that way. But with spectacles, it's less commonly done that way.
What about floaters and flashers? Tell us about that.
So floaters are a common aging change. As we get older, the inside of the eye, which is filled with a solid gel structure called vitreous, roughly where my fist is, this clear gelatinous structure gradually liquefies as we age. And pockets of fluid develop in the vitreous as a normal aging change. And some of us can see a small floater or two, which represents liquefaction of the gel. But as we age and reach the age of, say, 50 to 60, at least half of the population, somewhere in the age of 50 to 60, will experience something called a vitreous separation. And what that means is those little pockets of liquefaction coalesce into a big bubble, and that big bubble will rise to the top of the eye, and the solid vitreous will then drop down, and the vitreous will separate from the back wall of the retina in a sudden onset, which will be heralded by numerous floaters, very, very prominent floaters, not the one or two that seem to come and go,
I see.
but many very large, prominent, annoying floaters and or flashes of light.
And what flashes of light? Is it the same causation or something different?
So when the gel separates, it will move around and create traction on the peripheral retina, and that mechanical traction can sometimes create an arc of light. And if it's the right eye, typically the arc is to the outside of the right eye, or in the left eye, the outside side of the left eye, we call it the temporal side, and it's a quick flash or a quick arc that's over in like a tenth of a second. So floaters or these flashing lights or both can be associated with this so-called vitreous separation.
And are they sometimes an after effect of cataract surgery as well?
Yes, after cataract surgery, it's common for the vitreous to separate if it hadn't separated prior to surgery. It seems like the reason that happens is the lens of the eye is fairly large. When a small shim of plastic is used to replace this this moderately voluminous lens, the gel has more room to slosh around, and it's just easier to separate. But I should add, the cataract surgery simply makes that separation occur sooner than it would have otherwise. It doesn't really cause the separation.
What is the treatment for these? And is this really, are we getting into your area of specialization now?
So yes, as a retina specialist, probably most of our patients are referred for peripheral flashes or floaters because 10% of patients with those symptoms will have a retina tear. And if you look at patients with retina tears, about 2/3 of those untreated will develop a detached retina within 6 weeks, and a detached retina roughly presents as a blind eye. A curtain-like effect to the side which grows rapidly in size until blindness occurs. So untreated retina tears, a very serious problem, easily treated if they're caught early. So when the gel separates, it's smart to get the peripheral retina checked as soon as you can. Some general ophthalmologists feel comfortable doing this. It's a special technique called scleral depression. And what that means is you have to lay the person back on a chair, much like a dental chair, and you depress the peripheral retina with a thin stick. And you're actually pressing on the eyelid. And if it's done properly, it's a very gentle pressure. Most patients really don't feel any pain at all. But a novice or specialist early in their training, it could cause some degree of pain. But done properly, there's minimal, if any, discomfort to the patient. But that process of depressing the eye, indenting the eye, allows the ophthalmologist to see the peripheral retina, and it's the peripheral retina where tears tend to occur. So if you're doing the proper exam, it requires this very specialized technique. And if the ophthalmologist or the optometrist doesn't feel comfortable doing that technique, they'll often send the patient to us with this purpose in mind.
And is all your surgery laser surgery, or do you do other types as well?
So when a retina tear occurs early on, before the retina detaches, we would treat that with either laser or cryogenic retinopexy. Cryopexy or laser, the purpose of either is to create a scar around the tear, and that prevents the retina from detaching. The scar takes about 1 week to form. But if a tear is discovered and treated, the likelihood of a retina detaching is probably less than 1%.
Why don't you tell us about macular degeneration?
So macular degeneration is a common problem in the United States. It's the #1 cause of vision loss in older Americans. And roughly defined, macular degeneration is an aging change of the retina in the macula. And the macula is a very small area of the retina, the part of the retina that you use for fine discriminatory vision. And it's 1/100th of the entire retina. It's where most of the light is focused straight ahead, so to speak, as opposed to your peripheral vision. Macular degeneration, it has an increased prevalence with age. So if you look at 40-year-olds, for example, in the United States, approximately 1.5% of the population has it. But by the age of 80, approximately 15% of all women have macular degeneration, seemingly a little bit more prevalent in women than men.
And it's just aging? Are there any other causes?
Well, aging is the reason it's called age-related macular degeneration, and certainly genetics plays a role. There are many, many genes that we have discovered that are linked to this disease. There are 2 forms of macular degeneration.
Tell us about that.
One is called the dry type, and the other is the wet. But let me back up for a second. When we say a patient has macular degeneration, what we mean by that, as a retina specialist, we look into the eye and we see yellow spots called drusen, or pigment changes in the back of the eye. And these changes generally would be associated with mild visual loss. And these changes and the visual loss associated with these changes tends to slowly progress with age. Some patients with these yellow drusen, and some patients with pigment changes never get vision loss, and we would say that those patients have age-related maculopathy, not macular degeneration. So we're splitting hairs. Age-related macular degeneration means you have changes in the eye and vision loss. So the dry type is generally thought to be a milder form, and it's the most common type of macular degeneration. Probably 90% of patients have the so-called dry form, where you just have these pigment changes that I've described, pigment loss, pigment changes, and these yellow deposits under the retina. The more advanced form and the more serious type of macular degeneration is called the wet form, and wet implies there's fluid or hemorrhage, bleeding in the eye associated with the disease, and that type of macular degeneration typically causes severe vision loss and distortion, and can have a very rapid onset.
Is there treatment for it?
Well, there is a very good treatment for the wet macular degeneration. The treatment, if caught early, consists of injecting a chemical in the eye. And this chemical is injected with a very, very tiny microneedle through the white part of the eye, the sclera. Obviously, the eye is anesthetized and some antibiotic is instilled in the eye before the injection is administered. But these chemical injections typically are done in a series of at least 3 injections every 4 to 6 weeks, and sometimes they're carried on for many years. But in some cases, the macular degeneration will respond extremely well and the disease will regress. The dry type of macular degeneration is generally treated with vitamins.
And how common are either of these? Well, it seems like the wet is more dangerous. Is it less common than the dry?
Yes, 90% generally are of the dry variety. And if a patient presents with just the dry macular degeneration, we would highly suggest that they begin what's called the AREDS 2 vitamins, AREDS. If you go to the pharmacy, there's a whole aisle of medications that are, quote, for eye health. And unfortunately, the government has no rules or regulation when it comes to selling vitamins. So anybody can create an eye vitamin and market it as such. But in fact, the National Eye Institute studied vitamins and their application to eye disease, and there's one specific formula. It's called the AREDS 2, AREDS, Roman numeral 2, or formula. In this particular formula slows down the disease better than any other formula, and it's the only formula we recommend patients take. So if you're in the aisle and you see these vitamins, some are very expensive, some are less expensive, and some are promoted as eye health for older individuals. None of those vitamins have really been shown to have any benefit at all. But the AREDS 2 specifically, that formula is beneficial for macular degeneration. We don't recommend it for individuals with normal eyes. And the formula specifically has high doses of vitamin E, C, zinc, lutein, zeaxanthin, and copper.
What about diabetes in our eyes? I know that can be very important and devastating, and I guess we're talking about there's type 1 and type 2, and one is early onset that can be impacting but someone at a very young age, and then there's the other diabetes, which often hits as we're getting older.
So diabetes turns out to be a huge problem, and it's growing in terms of incidence or prevalence in this country. It turns out just under 10% of the US population is diabetic. And if you look at diabetic patients, eventually many of them will develop eye disease. And in fact, if you look at individuals over the age of 40, approximately 5.4% have some degree of diabetic eye disease. The longer the history of diabetes, the more likely you'll see changes in the retina. And fortunately, we now know that with good control of the sugar diabetes, meaning keeping the fasting sugar close or below 100 and keeping the A1C level close to 6, if you can achieve that, the chance of developing eye disease is much lower, and the eye disease, if you do get it, will be much milder.
Isn't a lot of it because there's a greater proliferation of diabetes, especially among those who are aging, because of dietary factors, the fact that more and more people are overweight, as well as the fact that more and more people are sedentary?
It's well known that the sedentary lifestyle and obesity are the major causes of type 2 diabetes, which is the predominant type in this country. And in fact, if those individuals could go on an aggressive diet and lose weight and shed their pounds and their body fat, most of those cases are totally reversible.
What are the differences between proliferative and non-proliferative?
So non-proliferative diabetic retinopathy is the milder disease that seems to occur first. And when we as retina specialists look into the eye, we see these tiny little specks. They're called microaneurysms. And for those of us who grew up in the 40s and 50s, you may remember on the older automobile tires, you would occasionally see a bleb in the tire, which is an outpouching of the tube. It would, and if you hit that thing, it would pop and the air would leach out of the tire. But the microaneurysm is like a small bleb in the capillary of the eye. It's just an outpouching, tiny little focal defect in the capillary, which again is in the macula primarily. And when they leak, these leaky microaneurysms can cause fluid buildup in the retina. The analogy would be if you took film and a camera and you put droplets of water on it, the picture would be blurry and a bit out of focus. The retina can absorb some degree of fluid, and the body will naturally pump it out. But if you have a lot of microaneurysms that leak this fluid, eventually you develop something called macular edema, and that can cause substantial vision loss. So non-proliferative diabetic retinopathy it refers to what we call background changes, microaneurysms, specks of blood, loss of circulation. The more advanced form of diabetic retinopathy is called proliferative diabetic retinopathy. And what that refers to is small capillaries actually grow into the inside of the eye, the vitreous cavity, for example, and act almost like weeds growing in a garden. These capillaries proliferate in the eye, and they can bleed and cause sudden, very large vitreous hemorrhages and sudden vision loss.
Frightening. What about issues involving retinal vascular disease?
Well, retinal vascular disease is a broad term that talks about strokes in the eye, basically. Blocked retinal veins and blocked retinal arteries. And these can occur in non-diabetics. They can occur in individuals with high blood pressure or hardening of the arteries, and certainly diabetes is also a risk factor. But the way a patient presents with retinal vascular disease typically is they'll just wake up one day and suddenly a piece of their vision will be missing, or everything will be very, very blurry. Recent research has shown sleep apnea can be a cause of retinal vascular disease, and we often recommend patients to be tested in a sleep study, especially if they snore or fall asleep easily during the day. And we've discovered in our practice many patients with sleep apnea as a result.
What are some other things you'd like to cover? I've been given a signal that we're down to 2 minutes, so I'd really like to share some thoughts with our viewers, about your specialty as a whole and other things, some words of wisdom to share with us before we sign off.
I would say
Miller.
probably the most important thing I would suggest to the audience would be if an individual has vision loss in one eye, or a lot of floaters, or some sudden change in their eyesight, I highly recommend they see their ophthalmologist as soon as possible, not weeks to months, but within days, because oftentimes it could represent a reversible or treatable pathology. Sometimes pathology caught early can be reversible, and in my field it's very exciting to see many diseases which were untreatable early in my training can now be treated and almost cured. But it still depends on the individual coming in and seeing their doctor. If the doctor says, I'm busy for 2 or 3 months, they need to see another doctor, or tell them that it's an emergency and
So
be seen immediately,
essence.
timely fashion, yes.
What about, so you're doing a lot more things with lasers. I mean, it's, as you said, you were on the cutting edge at the beginning of your career, and I'm sure it's much more sophisticated now.
Well, there's always technological changes, and one thing I've alluded to are treatment of diseases such as macular degeneration and these injections. By the way, the same injections that we use for treating macular degeneration are also used to treat diabetic eye disease and also treating retinal vascular disease. So it's exciting to see more and more diseases that were previously untreatable now can be treated. Unfortunately, sometimes there's substantial cost associated with their treatment.
Seems as we wrap up, kind of a word of wisdom would be, if something's bothering you in your eye, don't delay, consult a doctor, an ophthalmologist as soon as possible. Dr. Joel Miller, I want to thank you so much for being my guest on Gracefully Greying, and I want to thank you for watching Gracefully Greying.